Assalamu alaikum, everybody. I welcome all the audience from all around the world to today's webinar organized by Imamia Medics International Academic Council. First, I would like to introduce myself. My name is Samreen Fatma, and I'm associated with IMI International Academic Council as academic coordinator. Today, I have my co-host, Dr. Kiran Ijaz, in this session. She is from US and has been associated with IMI International Academic Council for past 8 years. Welcome, Dr. Kiran.
Assalamu alaikum, everyone.
Walaikum assalam. It has been a tradition of IMI International Academic Council to hold sessions on different health-related topics. This session is one of the continuation of the series. Today we have highly qualified clinical professionals here to discuss on the topic of coronary heart disease, blockages, heart attack, and the ways to treat and test them. This session will include awareness about this disease. Now I would like to introduce our first speaker, Dr. Ali Ammar. Dr. Ali Ammar is an interventional cardiologist and stroke interventionist. He is currently serving as assistant professor at National Institute of Cardiovascular Disease, NICVD, in Karachi, Pakistan. Dr. Ali Ammar has also received European diploma in stroke intervention and has been in practice for more than a decade now. Welcome, Dr. Ammar. Over to you.
Thank you very much. And today we are going to discuss on a very important topic, that is heart attack. And we will see why this is important. So we will move to the next slide. We are discussing it because it is now the leading cause of death worldwide. And if you can see on your screen, different causes of deaths worldwide, so you will see that cardiovascular diseases are at the top. In the next slide, you will see, next please. In the next slide, you will also see another data that is showing that it's a leading cause. Now, the question is that why this happens. Now, if you see in your homes, you have different pipes. And these pipes, if they are of iron, they get blocked gradually by the rust. Same happens with our vessels. That in the left side of the diagram, if you are seeing it, then there is some rust that is called a plaque, where the calcium, where different chemicals, they accumulate and they narrow the vessel. This narrow down is usually continuous after 20 years or 19 years of age, and it continue to grow in different peoples. We will see in whom it will grow. In the second phase, if you are seeing it, then you are seeing that it is blocking the flow. So if we move to the next slide, then it is blocking the flow. So what happens is that, so come back to the last slide. If it is blocking the flow, then in the next mid of the slide, you are seeing it that if it ruptures, in the second, when there is in written that the cap rupture, when it ruptures, it blocks the vessel. And in the third picture, you are seeing that if the vessel is blocked, then what happens is that the flow of the blood that is going to the vessel is totally blocked. So the third picture is showing how heart attack develops. If because of any cause, this rusting of the vessel or atherosclerotic plaque in the vessel, it ruptures, it blocks the vessel completely. And this is the reason behind the heart attack. Now move to the next slide. If you are seeing it here, we will discuss why this happens. So this blockage of the vessels is called coronary artery disease. And we will look into the different causes. Next. There is a wide range of causes for that and the risk factors. Number one is the growing age. Male gender is more prone than the female gender. Some have the family history in their genetics. So that affects ethnicity, stress in our daily life, that affects diabetes, hypertension, tobacco use, and more importantly, the high cholesterol levels. These are the different factors that affects the development and that is the risk factor for development of coronary artery disease. Next. So, looking at our diets, we have different sort of diets. They are very delicious, but they contain all the risk factors. They contain unsaturated fats, and that leads to the development of heart diseases. Next, please. And we also have to calculate our BMI, that is body mass index. You can easily calculate it by the calculators which you have at your home or in the Google. You can search it. And the most important thing is that from BMI, we calculate our overall obesity ratio. And we have to see whether we are in the normal BMI or we are in we have the risk factor for obesity and we are obese. So everyone should check their BMI. The more important thing that is important to the BMI is the waist hip ratio. And if the waist hip ratio is disturbed, then it is also the risk factor for development of coronary artery disease. Next. Another thing is the high cholesterol level. For checking it, we have to do the blood test that is called the fasting lipid profile. But sometimes in some people, you see it evident from the face or from the eyes or sometimes from the back of the elbows that there are deposits of cholesterol. So this also gives the clue of high cholesterol level. Next. These are the deposits in different areas, and if it is present, then it is most likely familial, and it's a big risk factor for development of coronary artery disease. Next. Now, important thing is that which cholesterol level is important. We have different cholesterol levels. For example, the LDL, low density lipoprotein, it is called as a bad cholesterol along with the triglycerides. So they both have to be low. But the good cholesterol, that is high density lipoprotein, it is a good cholesterol and it should be high. Whenever we check in our lab reports, um, it is important to control the LDL level and triglyceride level and to elevate our HDL levels. Next. Now, with every 10 milligram per deciliter increase in HDL level, that is the good cholesterol level, it is associated with 25% reduction in risk of development of ischemic heart disease or coronary artery disease. And another important point is that every 10 milligram per deciliter increase in LDL, that is the bad cholesterol, it is associated with 7% risk reduction in development of ischemic heart disease. Next. Um, Another important thing that we should promote the aerobic lifestyle, aerobic exercise in our life. Why? Because with the passage of time, with the busy schedules, our life is getting tougher and tougher, and we are not getting the time for exercise. So it is important to do the aerobic exercise. And aerobic exercise, remember, it means that the exercise that do not involve the shortness of breath, in which you don't feel chest pain. You have to go comfortably and you have to do it routinely. And if we move with 30 minutes a day, we can do it easily 5 days or 6 days per week. We can get 1 day off. So that helps us in overall building and avoiding the risk of coronary artery disease. Next. Now, this is the most important question. In the world, which one is killing more? The target killing, the terrorism, the attacks, or the smoking? The answer is obvious. Smoking is killing more people. If we see in the next slide, then there are different forms of smoking. For example, the vaping, nicotine patches. Next, there are different type of chewing things that are present and they cause the risk factor of ischemic heart disease. Today, every person is just like this. We are in stress, we have so much stress, and that is also leading us to the development of ischemic heart disease because our hormones that get disturbed, they get us prone to development of this disease. Next, please. So this is important. When we were young, we would sleep well. We enjoy sleeping. Today, we are not getting the time to sleep. But if we go to the sleep, we go to the bed, we have to shut down our computers, our mind, so we can get an enjoyable sleep. And remember, deprivement of sleep is now considered as a risk factor of coronary artery disease. Next. Now, coming to the point, what is angina pectoris? Angina pectoris is a pain that occurs just like this, that he is having in the picture. What he's having, this is our pectoral muscles. If there is pain and blockage in the heart vessels or in the coronary arteries, so there is pain. Remember, heart don't feel pain, but there's a referred pain from the heart that affects this region, that is the pectoral region. Sometimes it goes towards the hand and neck region. So next. So this pain is important, and that is called angina pectoris. But this is a typical sort of pain that occurs to anyone. We have to remember that the anginal pain can happen from the lower jaw to the both arms, not typically to the left or right side, and it can go up to the umbilicus. So any pain from lower jaw to the umbilicus can be of cardiac origin. Next. What is the principle behind this? The principle is the supply-demand mismatch. That usually is the phenomena behind different businesses in business community. The heart muscles have the oxygen demand whenever we work, whenever we exert, heart muscles need oxygen. And if it needs oxygen, then there is a problem in myocardial blood supply. For example, if the heart supply is normal, patient will feel comfortable. But if the heart supply is blocked because of any reason, because of the blockage of the heart vessels or any other thing, there is mismatch in the supply and demand. Next slide. Now, it is important, the duration of the angina. Um, what happens to the patient if there is a supply demand mismatch? Whenever a patient runs or move fast, he feels pain. He feels pain in the chest. And remember, it will only be till he stops hard working. If he is exerting and he get relaxed, this pain will be improved. So a stable angina will be most likely for a few minutes. Remember, it will not be for seconds. Some people say that I'm having this pointing pain just for a second, or something like someone is pricking me needle. That is not the heart pain. And if it persists for days, then remember the patient will not persist. So the cardiac pain should not be for seconds, it should not be for days. It can be up down in different days. It can aggravate or reduce, but it is not persistent. So usually it is for a few minutes, it persists with the exertion and it relieves with the rest. And if heart attack occurs, then the pain of the heart attack is usually maybe at rest, maybe in sleeping. Why? Because in heart attack, this blockage plaques ruptures and it suddenly blocks the vessel. Coming to the next slide. Now, there are different predisposing factors. For example, the anginal pain increases with emotions, any sort of emotion, happy emotions or sad emotions. It increases with exertion. Whenever someone exercises, run fast, or someone have a exposure to the cold or extreme weathers or heavy meals, it increases. And it is very important to know that when you do rest or you take sublingual nitroglycerin tablet, it relieves within few minutes. Few minutes means 4 to 5 minutes. So this is important. Aggravate on exertional, whether emotional or physical, and relieve by rest. Next point. Now, this is important. You are seeing in the lower side of the slide, there is a blockage in the road. And because of that blockage, the flow is reduced. On the Sunday morning, if you see this road, there will be no traffic jams. Why? Because the demand is less. But in the evening of the working days or in the morning of working days, when the demand is more, there's get traffic jams. So this is called stable angina. And in the upper slide, there was no blockage at the usual time. But when there is an accident, there is a sudden blockage in the road. And that sudden blockage of the road, maybe on the Sunday morning or maybe in the evening of the working day, it will block the whole road. And that will cause a trouble in the patient's life. So this is just like a heart attack. Next. Now, you are seeing the same thing. In the first slide, there is no first picture, there is normal flow. In the second picture, there is obstruction from the outside and it is causing blockage of the vessel flow. But it is related to the supply and demand. In the third one, where there is a written the heart attack, there is sudden blockage in the vessel and there is no flow at the next point. So this pain will not relieve by rest. That will not relieve by nitroglycerin. For that, we have to go to the hospital. And our next talk will be telling us what happens if we go to the hospital. Next. So this is a difference between the stable angina and the heart attack. In heart attack, there is sudden rupture of the plaque, while in a stable angina, this only happens when there is mismatch in supply and demands. Next. So remember, this blockage leads to the heart attack, and for development of heart attack, at least the pain should persist for more than 20 minutes. And if it is persists for more than 20 minutes, then this leads to the development of damage to the muscles. Next. So I will finish with this one, and we will like to see if this happens, what we have to do next with the next speaker. Thank you.
Thank you so much, Dr. Amar, for your insightful presentation. Now, I would like to introduce our second speaker, Dr. Ali Reza Musfi, who is an interventional cardiologist and is currently serving as Chief of Cardiology at Ocean University Medical Center, New Jersey, United States. Dr. Musfi is associated with the field of interventional cardiology for more than a decade now. Welcome, Dr. Musfi. Over to you.
Assalamu alaikum. Do you see my slides and my screen, Sabrine, and my cursor?
Yes.
Okay. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. My job is to talk about the testing and the management of CAD or coronary artery disease. The basic testing, which is done for for CAD, is a EKG. It records the electrical activity of the heart, and that gets transmitted onto the skin from where the recording is made. And certain patterns are established that give us the diagnosis. For example, in this EKG, there's this called the ST segment, and it is high. It is elevated, and that's an indication of a heart attack, heart muscle damage. The same ST segment may go down, it is depressed, and that is ischemia, which is decreased blood supply to the heart muscle without death of the heart muscle itself. Echocardiogram, or an ultrasound of the heart, shows this heart the way that is with the four chambers in that fashion. It's an ultrasound. It gives you an idea of the mechanical activity of the heart with regards to the heart muscle and also with regards to the valves. So EKG is giving you information on the electrical side. Echocardiogram is giving you the mechanical side and the valves. And then comes the stress test. Stress test in which you walk on the treadmill or given an IV injection of a medication, following which you lie under the camera, and the camera records these gamma rays that come out of you and records these type of pictures. So in this, there are two sets of pictures. One is during the stress when you're doing the exercise, and the other comparing it with the rest when you are resting. if you look at these sets of pictures, they are exactly the same. The same circle is a full circle on both sides over here, and this mango-shaped heart is the same in both sides. On the other hand, when there is when there is an abnormality, it manifests in this fashion. See this area in the front portion of the heart. This is the front portion of the heart, and you can see it in various places that there is decrease of that radiotracer uptake. And because of that, you can see there's a problem there. However, in the resting phase, you can see all that blood supply has come back. This represents blood supply to the heart getting decreased in the front portion of the heart, and that is represented by a blockage in the artery supplying that area, which is called the LAD, that is seen by that. And that is seen by a heart catheterization, in which we go from the groin or from the wrist, we pass a tube, inject dye, take pictures. The arteries supplying the heart are the left main, which is the main channel artery, then gets divided into the one in the front called the LAD and the one going to the left and back called the circumflex. There's another artery from a different portion of the aorta which arises, and that's called the right coronary artery. These are the main arteries of the heart. And this is a picture of the left ventricle itself, or the heart chamber, which is, this is the relaxed portion, this is the contracted portion. The difference in the two sizes is the amount of blood that has been ejected out of the heart, which is called the ejection fraction. So the amount of ejection fraction, the ejection fraction is usually 50 to 60% or more. That is the typical ejection fraction. Now, when you can do is during the catheterization, you can combine the anatomical heart catheterization, where you see the blockage, with the function of like a stress test by doing this procedure called FFR, in which we put a wire through the blockage and look at the pressure before and after the blockage. As you can imagine, the pressure after the blockage is lower than the pressure before the blockage, and that will indicate that this blockage is of importance. A person can have a blockage and yet not be functionally important. This test gives us that idea, that importance. So we talked about the stress spec, we talked about the heart catheterization. The same stress test can be done to involve the echocardiogram, where you see muscle changes and abnormalities under stress. But there are better techniques, radiological non-invasive techniques, which will indicate the plaque in its very early stages, called the coronary calcium as such. And what replaces invasive angiography is the coronary CTA, in which you can see the plaque, you can see the blockages, and it is done in an intravenous fashion. But the amount of dye used is probably less in the time of invasive angiography, or the same as that of coronary CTA. And another thing is that people who have allergy to the dye will face the same problem with both the tests as such. Heart muscle has certain enzymes, which when the heart muscle dies or gets damaged, they get released into the bloodstream. These are called troponins, and these troponins are going to be released in a certain pattern that gives us an idea of, and the amount that gives us an idea of whether you're having a heart attack or not. So this dotted line that you see over here, below that is acceptable, normal per se. But if it goes up very high and very early, that's an indication of a major heart attack. A minor myocardial injury can also take place, and that's a little bump over the normal phase. On the other hand, if there's inflammation, there's a minor increase and it remains steady in that fashion. This is the important slide. You can vary from being asymptomatic to having a heart attack. The reason for us to test is to not have that heart attack, not have those events, and catch this before you have that problem. So at the two extremes, testing is not important and not valuable at the two extremes. And when you're asymptomatic, you should not be tested. But those who have an actual heart attack or having a problem, there's no need to test them. You need to take them for doing procedures which will correct the problem. Where the testing comes into play is the intermediate people or the low risk. Just yesterday, I got called by a well-known internist who had a problem with one of our own kids. And because he was about 40s and in his 40s had jaw pain, and she wanted a heart catheterization without having any other issues as such. So I said he's either low risk or really asymptomatic, and he should go for calcium scoring rather than any major procedures. So scaling back on some of these things is sometimes more important than going and aggressively doing excessive testing as such. Now, how do we manage coronary disease? This comes into stable kind of situation and an unstable situation, but the medical management is similar in both. The medication nitroglycerin, it can be short acting, that is placed under the tongue, in which the action is immediate and it helps with the chest pain at that time. The long acting ones can be used once or twice a day and used for a long term purposes. It helps with chest pain. It relaxes the arteries and the veins. Beta blockers, metoprolol, carvedilol, atenolol, they lower the heart rate, the blood pressure, and they affect certain hormones in a local way, and thereby they reduce the workload of the heart. They are more effective in patients whose heart muscle is weak, that is where low ejection fraction is there. Calcium channel blockers, amlodipine, diltiazem, verapamil are a mix of both as such. You hear the word blood thinners there, but there's more to it than that in that fashion. And the antiplatelet agents are aspirin, the age-old aspirin that is going on from our grandfather's days, and P2Y12 inhibitors, which are clopidogrel or Plavix, ticagrelor or Brilinta, and there's another drug called prasugrel or Effient that is used a little bit less over here. Anticoagulants, they affect the certain clotting factors of the blood as such. They can be given by the mouth, warfarin or Coumadin. DOACs are the drugs that have replaced this. You've heard of apixaban, Eliquis, rivaroxaban, Xarelto, dapivirban, Pradaxa. Or you can give intravenously heparin or under the skin enoxaparin. The clot blusters, which were there a couple of decades ago for treating a heart attack patient, is because they actually dissolve the clot. That's called thrombolytic therapy. Not used as much because they also dissolve clots in, say, the brain or the stomach, causing bleeding in those spaces. So these agents can be used by themselves, single antiplatelet therapy, aspirin alone or a Plavix alone, or dual antiplatelet therapy, aspirin with a P2Y12 inhibitor, or triple therapy, aspirin, P2Y12 inhibitor, and also an anticoagulant like DOAC in certain conditions. Now, remember, these drugs are helping with thinning the blood and thereby preventing the clot, but they're also causing bleeding. So the key is to balance the clotting, which is a bad thing, versus another bad thing, which is excessive bleeding. And for that, the more recent data is showing that all these recommendations have become shorter duration of this therapy, and there's less meds. So we used to give the dual antiplatelet therapy for a year in certain cases. We are dropping the aspirin after, say, a month. When we are using the triple antiplatelet therapy, we are dropping the aspirin very early after a stent placement in those patients with irregular heartbeat. Cholesterol. Cholesterol management, you heard from Dr. Amar about total cholesterol, bad cholesterol, the good cholesterol, the triglycerides. But there are patients you see who have all these things going for them, and yet they have problems. They have a heart attack, they present with a heart attack. There may be other things that we don't have all the studies on, and that may be the way to go in future, which is the particle size of these, the HDL and the LDL, the bigger is better. LP little a, ApoB. These are other fractions of the lipoprotein that need to be studied, and they have a deleterious effect upon that. By the way, they get affected not by drugs, but by healthy lifestyle. There, we need clues. Inflammation, the clues for inflammation. Dr. Amar talked about this plaque rupturing and bursting before the heart attack takes place. That inflammation can be seen by this enzyme called CRP, or the plaque. Early stages of plaque deposition may be seen by the calcium score. The clinical state is important in determining how aggressive you want to be with your cholesterol management. The people who are having a heart attack or unstable angina, or those who are diabetics, who have a stroke, who have peripheral arterial disease, etc., you need to be more aggressive with them. The lower the LDL, the better. That's the basic principle. Just remember that. I know the bad LDL, the bad cholesterol LDL number is given as 130 and below. But in these cases, it's 100 and below that you want to go for. It's better to go for 70. And in certain high risk in individuals, it's best to go with 50. For what are the high risk individuals? Specifically for this audience that I'm talking about is South Asians. South Asians are a very high risk by themselves. We constitute about 25% of the world population, and we are accounting for about 60% of the world's coronary disease as such. Our risks are greater, are 2 to 3 times greater. When we get hospitalized, our mortality and our complication rates are 3 to 4 times greater. We are getting these heart attacks 10 years earlier. So there, the particle size, this LP little a, ApoB, all that may be playing a role. And we need to go for number less than 50 rather than 70 as such. So the idea behind statin use is to go with high intensity. You go with a large dose as such. And if you have not achieved your goal, you go to other drugs like ezetimibe or Zetia and a PCSK9 inhibitors, which are injections that are given per se. Now, the other side of the treatment, the non-medical side, revascularization. As is angioplasty, stenting is called percutaneous coronary intervention, or PCI. Coronary versus CABG is coronary artery bypass grafting. So this is the way we do our stenting. The plaque builds up over a period of time, just like rust collects within the arteries and the water pipes. You pass a wire across it and a balloon, and the stent is crimped on the balloon. Then you inflate the balloon, thereby the stretching out the stent. You deflate the balloon and remove it, and the stent remains as part of your body permanently. That's how the balloon angioplasty is done. Let's look at this video. Is this the artery? You're seeing the plaque build up, and now there's the wire coming over that, the balloon and the stent, enlargement of the balloon, and then deflation of the balloon. The wire is out, the stent remains. So let's look at it again. Okay, so that's how the so the angioplasty. The one thing that you have to understand, angioplasty, stenting, etc., is quite dramatic. Every blockage we want to take care of it, but angioplasty and stenting really do not save lives, but they reduce the rate of angina or chest pain. The multiple studies have shown that it's not about the death, but it is about chest pain reduction, the reduction in the number of medications that you're taking over a period of time. This Courage trial in 2007 laid the ground for showing that we were doing too many angioplasties on medium-sized blockages and severe blockages, which didn't need it. Multiple studies since then have come back. We know a lot more about where we stand. After Courage, it went the pendulum swung the other way, in which every severe blockage was also being questioned as such. Now a lot of doubt is creeping up through many of these studies. Like, for example, the more recent ischemia trial, when it went on for a longer period of time in the next trial called Ischemia Extend, there was benefit shown at 4 years. So we know a lot more about these conditions. After that Courage trial, this was a Newsweek picture that came out that all the healthcare workers want to push for towards the cath lab to this cardiac patient, and all you have to say is no. And that was one extreme. And after that came these multiple agencies that put together the appropriate use criteria for doing stenting, etc. And since then, things have settled down quite a bit. And if you look at this blue line was the uncertain, and the yellow line is the inappropriate. They're all coming down. The appropriate use of angioplasty stenting has gone up significantly, and that's what we want. In the right patient, it's a very useful procedure. Bypass surgery. You can have a single bypass graft, you can have two bypass grafts, you can have triple bypass grafts, you have quadruple bypass grafts. So people think that quadruple is way more riskier than the single. It is not. Each of these grafts takes about 15 plus minutes to do, but the risk involves in the anesthesia, risk involved in clamping the aorta with this regard to stroke, etc. You want to, in most cases, just because you increase the number of grafts, the risk doesn't increase per se. But remember, in a case of angioplasty stenting, if a road is blocked, you are taking care of the blockage by pushing the stones on the side or the cars on the side. In the case of bypass surgery, you're not doing anything to the blockage. What you're going is going beyond. You're creating a detour of the blood beyond the blockage and allowing blood flow to go through. Where do we do one and the other? Bypass surgery is best done when there is a left main involvement or with diabetic with multi-vessel disease, more than two vessels are involved, two or more vessels are involved, or when the lesions, the blockages are very complex looking, the syntax score is high. And those people who don't fit those criteria are very good with angioplasty, stenting per se. Acute coronary syndrome. We were talking up till now about stable patients, chronic disease. The acute coronary disease, as Dr. Amar pointed out, you may have a blockage, which there's a plaque that has been sitting there for many years, and one fine day, because of inflammation, it ruptures, forms a little bit of a small clot, restricts the artery to some extent, does not completely stop flow. That is unstable angina when the troponins are negative, or a non-STEMI, a small heart attack when the troponins are positive. Or you may have the plaque that ruptures, a large clot forms, completely blocking the blood flow, so the heart muscle is dying. And that is the ST elevation myocardial infarction, the first slide that I showed you before. Acute coronary syndrome. Every 30-minute delay in opening the artery, which is causing the heart attack, increases the relative risk of 1-year death by 7.5%. That's why it's important to open the artery very quickly. Time is heart muscle. You stabilize the patient, give them the blood thinners like IV heparin, Lovenox, enoxaparin, and give them antiplatelet agents, aspirin and Brilinta and Evifian are the ones that have been given for acute coronary syndrome. If not, then give clopidogrel or Plavix. In non-STEMI, in the small heart attack category, If the patient is unstable, you take them to the cath lab right away. In those who are high risk, there are certain criteria for this high risk. If they are high risk, you take them within 24 hours. Or if they are low risk, you take them before discharge to the house. Thrombolytic therapy, the clot busting agents, if this is secondary. If only PCI cannot be performed, if the artery cannot be opened within 120 minutes, then give thrombolytic therapy. And if you give that, give it within 30 minutes as such. And PCI. The studies that I was talking about earlier are not acute coronary syndrome. Those were the stable patients. There's these unstable patients. There's absolutely no doubt that stenting, balloon stenting, etc., is very, very helpful and life-saving as such. So you can aspirate the clot out. Bypass surgery does not play a role in the acute heart attack patient as such, but in non-STEMI others it does, if you've had that. Because in a heart attack situation, you are dealing with heart muscle damage, and it takes a long time for a heart attack to play. If the person is in real bad shape, they go into cardiogenic shock. That's a whole different discussion. I'm not going to go into that. The other management which Dr. Amar touched on, tobacco cessation of any kind. In India, Pakistan, they chew tobacco. So that also is not just smoking, but chewing tobacco and vaping is the new thing, which is horrible. Alcohol and substance abuse, especially cocaine abuse, exercise, the importance of exercise, especially cardiac rehab after position is huge. Weight loss is extremely important, and we have these GLP-1 agents which are there nowadays, getting very popular. Unfortunately, people are using them to almost maintain their weight by continuing to eat, living unhealthy, but taking medications. That's not what they're supposed to do. Mental health, the depression plays a huge role, and control of the concomitant medical conditions like high blood pressure, high cholesterol, diabetes, kidney problem, anemia as such is important. So we have talked about the heart muscle being affected because of these tight blockages. But the important thing to remember is that it is not the total blockage or the tight, very tight blockage which causes the most damage. It is those medium-sized blockages which cause the most amount of damage, because things have not been established well. There are no collaterals that are growing for multiple reasons. So our job is to concentrate not on the after effects like I do. I'm an interventionalist. I'm going after the blockages after there is a blockage or after the blockage has ruptured. The place to attack is before. And before it comes to that stage, to calm down those vessels. We have amongst us Dr. Arshad Qayyumi, who is one of those individuals who's working very hard at that stage. People like him are more important for the future than people like me, because I'm coming into fact after the fact. So from your end, people listening and watching, prevention and healthy habits are the most important things. Don't wait till you have a heart attack to change your practices as such. A glimpse of the future. The flow, like the traffic. Say you're going at 98 miles per hour. If you are on Autobahn or somewhere in Utah, you're going at 98 miles per hour, and Montana. So and there's at one stage after certain thing, the traffic has slowed down to 60 miles per hour. That is because there was an accident or some blockage in the middle somewhere. So you can put in a stent and have the same 90 miles per hour speed. And this is the flow of the blood. You can be seeing, we are all already doing this by a CAT scan, etc. Okay. And the other thing is doing robotic PCI. In July, robotic PCI was done, the first one in July of 23 in Xinjiang province in Uyghur hospital in China. After that, this is in France. This is Dr. Muhammad working. There's a nurse inside the cath lab. He's sitting with a joystick miles away. It can be in different parts of the world. And you can be doing this procedure, and he's the one advancing this wire across and the balloon and any place to stent in this video that is there. So to summarize, the medications that we talked about was nitroglycerin, beta blocker, calcium channel blocker. We compared angioplasty stenting, which is percutaneous coronary intervention or PCI, to bypass surgery. We talked about the small heart attacks called the non-ST elevation MI, how that is treated with anticoagulation, antiplatelets, and we talked about various timings of when the heart catheterization will be done in those cases. STEMI is as early as possible. You want this heart attack to be corrected by opening of the blood vessel. We talked about the clot busting agents, which are secondary to doing angioplasty, stenting, etc. Healthy lifestyle is the key. And we talked about why non-obstructive coronary disease is and prevention is far more important than treating. As our Mawla Imam Ali alayhi salam has said, the disease of the heart is worse than the disease of the body. Thank you very much. Assalamu alaikum.
Thank you so much, Dr. Musfi, for a comprehensive and educational presentation. Now, I would like to invite Dr. Kiran for leading the question answer session. Over to you, Dr. Kiran.
Thank you so much, Samreen. An excellent presentation by both Dr. Musfi and Dr. Amar. Now we'll open the floor for question and answers, and I request everyone who wants to ask a question to either send a message via chat or use the raise the hand option. This option is under reactions. You can select the option like somebody is already writing in the chat. But please, I request everyone not to share any personal information. This recording will be on general forums. We do not want anyone's personal information to be shared. So let's see what the first question is. I'm on cholesterol management. However, my PCP tells me to take aspirin, baby aspirin, and my cardiologist say to take it every other day. So one PCP is saying that the baby aspirin needs to be taken every day, while the cardiologist is saying every other day. Either of you can answer, please.
I can go for it. Cholesterol medications depends upon what the type of the metabolism of that medication is. It's typically on a daily basis. There must be some reason. In some cases, we go with the long-acting medications, like rosuvastatin. They, especially if the patients are having a problem in low dose, we can go every alternate day. But they should be taken based on the instructions given by the pharmaceutical company. That's where the studies were based on.
The question is about aspirin.
Oh, aspirin every day or aspirin? I apologize. The aspirin should be taken on a daily basis also. Baby aspirin. It does affect the blood thinning over a period. It effect lasts for 7 days. Okay, that's why you have to stop 5 to 7 days before any surgery, etc. So you stop the medication because all the effect of it needs to be gone. But for its effect to be persistent, it should be taken on a daily basis.
Dr. Amar, would you like to add?
No, I think the answer is given. There is a risk calculator that is called ASCVD risk calculator of American Heart Association. You can go on internet and calculate your risk for the development of ischemic heart disease. And that will easily guide you whether you have to take it or not. Thank you.
Okay, thank you so much. The next question is from Dr. Huma Nikwi. Please comment on statin therapy and long-term effects on muscles, especially cardiac muscle and dementia.
Okay. So I think this has taken the airwaves more than it should have a while ago. The effect of the cholesterol medications are metabolized in the liver and in the muscle. That's why you get muscle aches. So typically you have pain in the heart, in the skeletal muscles right after you start taking the medications. So and you stop taking the medication. We also follow the certain blood tests. Like we're not following in most of the cases. We just stop the medication where they don't have. But you can follow the blood test to see if there is any skeletal muscle damage per se. So if there is, then you stop it. We follow liver function tests to make sure that they are not affecting that. So over a period of time, we do these tests on a regular basis and prevent the side effects of these becoming a major problem. In a small number of patients, we have to stop the medication, and now we have alternatives which we can use in those cases as such. Dementia. There has been some data about about the use of statins causing the dementia. There's no head-to-head study that has shown that. There's been some data about it. It was blown out of proportion in social media as such. But whenever you take medication, there's no medication without side effect per se. So when you weigh the amount of data that is existing and the effects, the advantage of reduction in heart attack, reduction in stroke, reduction in kidney problem, and peripheral disease, etc., outweigh any small suggestion of dementia as such.
Great. Dr. Mar, would you like to add something?
No, I think it's good answer.
Excellent. Our next question is about risk factors for coronary artery disease. And the question from Ijaz Haider is, cigarette smoking is a well-known established risk factor. Is there any evidence for cannabis as a risk factor for coronary artery disease?
Did you want to take Dr. Mar?
Yeah, Dr. Musa.
Okay. If you want, basically, cannabis does not have the same deleterious effect as say cigarette smoking does. But many times, the cannabis is impure. The impurities, and even in cocaine, it is the impurities that cause the damage per se. Cannabis does have long-term multiple problems as such. And but it has been accepted over here, just like alcohol has.
Great. Our next question is, as part of our longevity clinic, we do CT angio for most of our elder patients with moderate risk versus calcium scoring. Are we overdoing this?
Absolutely. Calcium scoring should be the one that is to be done first, not as coronary CTA, unless it is in. There are clear indications for both of them. In an asymptomatic individual or a low risk individual, calcium scoring is clearly the better one. In a moderate risk individual, it could go either way depending upon the clinical features as such. It varies from patient to patient as such.
Great. The next question is, what is the HS troponin and HS homocysteine screening role in our patient care pedigree?
I didn't know there was a screening role per se, but there is. These are agents that are tested. They occur as a result of heart muscle damage. So taking an asymptomatic individual and just testing them for troponin is not anything. I think it's more research or oriented rather than doing therapies for that. I think that Dr. Qayyumi, is there any data on that, doing this on a routine basis in an asymptomatic individual?
No, as you said, there is some research to show that even elevated high sense troponin levels within the normal range,
right,
not the heart attack range,
right,
is associated with increased risk in the long term. But this is not advised. There is no guidance around this. It is used in research studies. As for homocysteine, it is a known risk factor. But whether it's an independent risk factor, we don't know. If you come across an individual with very high risk, somebody's had a heart attack, but the cholesterol is normal, blood pressure is normal, there's no diabetes, there's no family history, etc., then you might check for these unusual things, the so-called other risk factors, which would include screening for homocysteine, but it's not done routinely.
Our next question is, I think, two-layered. The first question is coenzyme Q10 helpful along with statin? How about omega-3? That's the second layer of that same question.
So I don't prescribe it. I tell my patients that it is not something that is very useful. People do report that with statins, the muscle effects, etc., are lower with that. And I think this has been addressed in the new guidelines as having no benefit, both of them, along with the oral omega-3. There are treatment with omega-3 that is done, but that is in much higher doses. The ones that are sold over the counter, they are not doing much benefit. However, I would urge you to get that same omega-3 in a natural way, which is in the form of fish and eating oral stuff, which will give you those omega-3s versus omega-6s as such. You want to go the natural route rather than pills.
Okay, so next question is for individuals recovering from a heart attack or living with angina. What are the most effective ways to rehabilitate heart health and reduce the risk of future cardiac events?
Okay. Cardiac rehab has been well established as a important indicator after a heart attack, after an angioplasty, after bypass surgery, etc. Now, that may not be available to everybody, and it may be expensive for some. It may not be expensive, but you can do similar kind of activities at home. Exercise, healthy lifestyle, stopping smoking if you were smoking, those things that we talked about, weight loss, especially in the abdominal, the BMI, but losing it in the abdominal girth is way more important for South Asians than it is for the Americans as such, because that's where the fat deposition takes place. Avoiding processed foods, eating healthy, exercising. Exercise has been studied in a variety of different ways. You may want to exercise every day, or you may do it every alternate day, or you may even be a weekend warrior by going once a week. But that is still better than doing nothing at all. It's not only coronary disease that exercise has helped, it's cancer also that exercise has helped. So all these things are to be used for both people who have had a heart attack and those who have not had a heart attack. That's the important thing. We need to concentrate on the ones who have not had a heart attack.
Great. Next question is about ejection fraction. Does ejection fraction decrease with aging, and what is a healthy EF?
Definitely, it do not decrease with aging, and there is no relation. If there is no coronary artery disease or heart issue, it's not 100%. Some people think that our heart is functioning at 100%. Normal ejection fraction is 55% or more, and it usually decreases with any disease or coronary artery disease, not with the aging.
Great. Next question. I'm rushing now with the questions because we are about to finish, and I think this are the last two questions that we will take now. So the question is, how often should calcium score be done, and what intervention can be done after that?
Dr. Amar?
Maybe I can take it. The calcium score, if it is done and it's 0, it should be repeated after 5 years. Now, you can repeat it whenever you like, but the recommendation is you can do it after 5 years. If it is high and you know that you have, what it means is that you have plaque buildup in your arteries and you should be treated. with aspirin and statin to start with, and anything else that's causing the heart disease. Say if you have diabetes, that needs to be treated. If you have high blood pressure, that needs to be treated. However, if you have done it and you have started the treatment, there's no need to repeat it. There is no value in repeating the calcium score once you've made a decision based on your original calcium score, if it has been above 0. So I hope that's clear. Stenting and calcium score are unrelated. In other words, the likelihood of having more disease is greater. Blocked disease by blockages are there, which are amenable to stenting. Those blockages are more likely to be present in people with very high calcium scores, but there is no real strong relationship between the absolute calcium score and the amount of blockages you're going to have. So one thing doesn't lead to the other. The reasons for stenting are completely different, and I think Dr. Muswi presented that reasonably well.
Great. Last question now. What do you do with testing for lipo A and EPO B in your practice?
Arshad bhai, you should take that.
Apolipoprotein, what's called LP little a, is another risk factor for developing this atherosclerotic disease or plaque, coronary artery disease. It's like LDL. It's a similar particle but different, and having very high levels they often run in families. There are some racial differences. For example, people of South Asian origin, about 20% to 25% will have high LP little a, and it is an independent risk factor for developing this condition beyond these other risk factors that we talked about, like diabetes and having high LDL cholesterol, etc. At this moment, there is no specific treatment for LP little a, although there are many drugs in trials now, which will become available in the next few years, which will then allow us to treat people who have very high LP little a levels. So you can have one measured, and then you'll know that when these drugs become available, that you'll be a candidate to have treatment for it and therefore reduce your heart risk, if that's what these drugs do. But we don't have that evidence or the drugs available at this moment. ApoB is like LBL. It's a part of the LDL particle. So you're measuring same tests or similar tests, and there is some discussion as to which is a better measurement. They're not routinely done in most visits that you'll have with your doctor, at least in the US or in the West. In South Asian countries, it's done a little bit more frequently. And it's thought that in that population that it's a better way of measuring risk than it is measuring LDL. But once you know one of these numbers, it's pretty clear what your risk is. So those are these two lipid particles, LP little a and ApoB, emerging, if you like, as risk factors, but at this time, they're not routinely measured.
I did mention that it's going to be a last question, but now Dr. Rizvi himself has actually asked the question. So I'm going to ask that, sorry, and then close. So Dr. Rizvi is asking about your opinion about niacin as treatment for LP little a.
LP little a levels can be reduced by using niacin and PCSK9 drugs a little bit. So if somebody's had a heart attack and the only reason why they had it was high LP little a levels, then these would be alternative treatments at the present time, where there is no specific treatment for LP little a. The other thing I wanted to add about LP little a is that unlike LDL, you don't have to keep measuring it. It's fixed. You're born with a high level, unless you're treating it. And then you're trying to reduce it, then obviously it's worth measuring it. But in general, as a screening test, it needs to be done once in a lifetime.
Excellent. Thank you so much for the panelists to give us a deep insight about all these questions. Over to you, Samreen, please.
Yeah, thank you so much. I would like to thanks both of our speakers for their time and creating awareness. And I would also like to thank Miss Kiran for her efforts. Also, Dr. Kayumi for guiding us on the topic and all the preparations. And lastly, for our audience, thank you so much for joining us and being patient. Inshallah, we will keep bringing such informative webinars in the future too. Thank you for being there. Allah Hafiz.